To further inform us about payment considerations and financial incentives related to population-based models, we've invited a variety of esteemed experts from across the country. After all four have presented, our committee members will have time then for questions. The full biographies of our panelists can be found on the PTAC website, along with other materials for today's meeting, so I'll briefly introduce our guests and their current organizations. So presenting first, we have Dr. Mark McClellan, the Robert J. Margolis Professor of Business Medicine and Policy and the founding director of the Duke-Margolis Center for Health Policy. Welcome, Mark, and please begin.
Great. Thanks very much, Paul. It's great to be with you and all of PTAC. I'd like to give a special thanks to PTAC. Since the beginning of this organization, you all have worked really hard to try to make payment reform and related supports for transforming healthcare work for every diverse type of physician. I found the work very valuable, and Paul, a special thanks. I'll be talking about some of the topics that we've discussed around specialty payment reform and specialty engagement in comprehensive care models today. So just moving quickly, you all have seen this next slide, the CMS comprehensive vision, which was just referenced in the last session, I'm sure has been over the last couple of days, to get everyone in Medicare, almost everyone in Medicaid, really try to get our entire healthcare system moved towards comprehensive relationships that are founded on a strong, coordinated, accountable primary care foundation. There's been a lot of work in payment reforms done to address that. I want to focus on the next slide on some extensions to make these comprehensive models really work. Three areas where our center at Duke has been focused. Number one is on multi-payer alignment. There's some references down there at the bottom to take steps to increase directional alignment across multiple payers towards common goals to reduce the burden of adopting effective alternative models and to increase the critical mass of support for them. I'd refer people to the Healthcare Payment Learning and Action Network, a public-private collaboration that CMS and we and many other organizations support around the country to advance those goals. Glad to talk more about that. Second is to make these models work for addressing equity and work for underserved populations. Remember, most of the financing for those populations comes not from Medicare, but from Medicaid, from HRSA, from other sources. So there are steps that CMS can take, but also need to integrate financial alignment steps around the goals of comprehensive care from a range of other payers. There are a lot of organizations in that space that are doing some things differently and steps that we can take to help them. And then what I want to talk about today, which came up a little bit in the last panel, building off some of the excellent work on evaluating payment reforms to date in the specialty payment space, is how to engage specialists more effectively and comprehensively in being part of these models. The next slide highlights that we've had some limitations so far. Even though ACOs are 30% plus of the traditional Medicare population, probably in some form a larger share of Medicare Advantage, they've grown a lot. We've seen limited impacts with many specialists not even knowing or really being well supported in participating in these comprehensive care models, and some limited changes in operations. I'll come back to this and glad to discuss it further in some of the evidence we've seen on hospital-based ACOs. In fact, many physician specialty ACOs are taking their first steps into engaging specialists by trying to do more care coordination themselves with that expanded advanced primary care payment and looking at data and seeing if they can selectively refer. That's not really a comprehensive, coordinated effort engaging specialists. So there is this misperception that ACOs and comprehensive care has so far mainly been about primary care providers, even though there are some exceptions, specialists managing some patients and even some conditions and some longitudinal specialty care models like I think Nancy will talk about oncology a little bit later. We're seeing some steps in this direction, but I think a long way to go. Next slide. is just a reminder of this is important. So even if we're expecting shared savings and bigger primary care payments to account for an expanded primary care role in this effort, the fact is most of the money and most of the care that people get when they have a serious condition involves a specialist, and that isn't going to change anytime soon. So the more that we can do to engage specialist care directly and align those finances too, the faster we're going to get to those comprehensive care goals for CMS. And this is really important, as the next slide shows. As you think about care from the patient's perspective, specialists are important, and CMS has recognized this. They've released an initial specialty care integration strategy earlier this year. They're planning, I think, to add to that. They've highlighted the importance of specialist engagement to support comprehensive care coordination, to advance health equity, since a lot of the equity issues exist where there's not good comprehensive specialty care engagement, good access to comprehensive care, and a lot of steps that CMS is in process of taking now. So PTAC focus on this topic right now is particularly timely. Next slide. And I would just also highlight, if you think about care from the person perspective, comprehensive care involves advanced primary care, but increasingly as you go through your care journey, having more advanced conditions, whether it's cardiovascular, musculoskeletal, you name it, that involves more specialty engagement as well. Part of it's for the specialty care needed, part of it's for overall coordination. So, some of this is acute episodes where episode payments have focused for major procedures and hospitalizations with complications, but a lot of specialist involvement involves collaboration with primary care and other providers outside of those particular episodes, where we've seen some impacts from a set of payment reforms so far, but that's not where most of healthcare and most of specialty care is actually delivered and can influence. The next slide. Just to highlight an example of this in some of our papers, we go into this in more detail. This is work on musculoskeletal conditions from a longitudinal patient journey perspective that we've done with Kevin Bozick, colleagues at Dell Medical and others, just highlighting how many opportunities there are compared to current practice for an early triage engagement, maybe involving a combination of a specially trained physical therapist and orthopedic coordination to evaluate the best path forward for a particular patient based on their orthopedic findings, their pain, and especially tracking their functional status over time, something that's not done in routine care. In these care models, Dell and in a pilot at Duke and other places have found we can substantially reduce the admissions for major procedures, get better functional outcomes for patients, which is what really matters for this condition, and lower costs at the same time, but it requires a significant redirection of resources and redirection of engagement of the specialists as well as primary care to set up these and sustain these team-based care models. Hard to do with a shared savings or primary care focused ACO model alone. So next slide. This kind of finding, I think, exists for other common conditions. Paul and I have talked a lot about cardiovascular care. Cancer, we've already got, as we'll hear about later, an oncology care model and evidence, and would think about that even from a more longitudinal perspective, like oncologist engagement in efficient pathways to diagnose a patient, get them into timely and appropriate initial treatment, and then oncologist engagement and coordination after a patient survives that initial episode, which fortunately the vast majority of patients are doing today. We have many more cancer survivors who need chronic coordinated management to prevent recurrence and provide ongoing confidence in their condition too. The next slide. So these are important. And if you look at spending, this is from work by Francois de Brantis and some of our colleagues previously at Signify, in these specialty conditions, some of that spending occurs in episodes, but as I just was illustrating with musculoskeletal and some of these other examples, if we could direct some of the resources that go into those costly complications, those specialty procedures, et cetera, into better longitudinal management, a better experience across that care pathway with specialists actively engaged, you can see by specialty just how much resources are engaged, could be redirected and potentially spent better if we can avoid some of the acute procedures, acute admissions with complications, other specialty services that reflect complications, not effective disease intervention and ongoing patient management. Next slide. So we've developed some proposals for nesting condition-based payment models within the ACO program. This is not a separate and independent effort. The idea is building off the acute episodes with a specialty kind of per member per month payment around it for the organizations that are engaged in comprehensive care that want to work more directly with specialists and create a clearer, obvious path for sustaining some of these models that require new care pathways, different approaches to team management, et cetera, for specialty care. Some MA plans are already doing this. They've gone to PMPM, condition-based payments to specialists to coordinate with. This only works well within a total cost of care model where you've got primary care groups or a health system already engaged, or they've moved to just a flat, not per patient payment, but just a flat population-based payment for providing this care. That creates new flexibility. You can combine that with accountability that really engages specialists much more than in a model directed to primary care providers. So how'd you get there? Just a few last quick points here. Next slide. First of all, CMS and other payers have data now that can be used to describe longitudinal condition experience for patients, not just acute episode or procedure, but experience over time that patients are having. Procedures or admissions. You can work with the specialists on identifying ways in which outcomes could be improved and maybe utilization could be modified, if not spending savings, with data that's available now for organizations that are trying to implement these models and everybody else. Second, could start with a condition-based model, offer a few options. Maybe one is a small side. And that too can make a big difference. Third, the bundled payment programs, this is a little bit beyond my scope today, have shown some important effects. But I'd like to see a path towards more mandatory adoption of those acute episode payments, but nest that within these condition-based models. And fourth, making this a more integral part of ACOs we think can happen in two ways. First, for the physician-led ACOs especially, these condition-based payments would be voluntary. CMS could set up a model for how they could be implemented to substantially reduce the costs of specialists who want to play more of an active, coordinated role in longitudinal patient management to coordinate with the primary care groups, and they can renegotiate just how big to make that payment. If the primary care group thinks that they can do more of this specialty type management, they could take on more of that role as well. But we need a clearer, certain path, an easier path for those negotiations and that coordination to occur. Second, for hospital-based models, we think perhaps these approaches should be mandatory. I don't have time to go into to it here, but for many hospitals, the margins for the procedure-based elective admissions are higher than they are for medical, creating an opportunity to do okay as a hospital-based ACO by reducing your medical admissions, doing some population-based management, but increasing the number of specialty procedures performed, some of these elective procedures. In contrast, if there's a mandatory shift of some of those resources into specialty population management, it changes the financial dynamics for a hospital-based ACO in a way that will make it much more sustainable to implement these team-based approaches to longitudinal specialty management. So, Paul, others, thanks very much for the time today, and look forward to the rest of the discussion.
Thanks, Mark. A very helpful presentation. We are going to save all questions from the committee until the end of all presentations. So next we're going to hear a presentation from Dr. Joe Francis, the Executive Director of Analytics and Performance Integration in the Office of Quality and Patient Safety at the Veterans Health Administration. Please go ahead.
Thank you, Paul. And I think I'm going to amplify some of the remarks that Mark just had about what you can do within the global payment environment. If I could have the first slide, please. So to give you a sense of context, because as Amol said in the prior session, the type of delivery system really matters. Here's just a brief overview of who we are in the Veterans Health Administration. We are arguably the largest integrated healthcare system that covers both the entire United States as well as many places overseas, Guam, the Philippines. We even have clinics that serve veterans in Europe, and we have a telehealth reach that's global. We have 4 statutory missions which impact how we perform and the efficiency. In addition to care delivery, we provide education for the majority of the U.S. healthcare trainees. That's medical students as well as nursing, allied health, physical therapy, and many others. We have a research mission, and we have a statutorily defined emergency support mission. We provided assistance to thousands of non-veterans during the COVID pandemic. We provided millions of articles of personal protective equipment, supported vaccination and testing drives all across the country. These are important contextual factors and probably account for a little bit of additional inefficiency in our system. We call that resilience and flexibility so that you can respond when something unexpected happens. Next slide. Our healthcare system, as I mentioned, is national in scope. It is divided into 18 integrated service networks, each with their own administrative and clinical leadership. We have 1,300 sites of care, and that's not counting our telehealth and our mobile clinics, which again allow us to be very flexible across the country. Next slide, please. Our characteristics, I'll just say, a global budget, which is set annually by Congress, but it's a biannual system so that we get 2 years of funding, so we aren't necessarily constrained by continuing resolutions, and we can do a little bit of longer range planning than simply for 12 months. Our providers are salaried, and most of their pay is determined by base pay, which is set by government, market pay, which is a formula based on specific specialties, and a very small proportion, and we're talking maybe 5% on average, is performance-related pay, and that's typically related to quantitative performance metrics around quality, as well as other things that are probably more locally driven, like service on committees, responsiveness to veteran needs, and so on and so forth. Our system is platformed in primary care. And unlike many private healthcare systems, we have direct attribution of performance to the primary care team that the veteran is assigned to. So we don't use formulas. We look at the folks that are basically standing up and taking account for that veteran. Other things that we work with is a national prescription drug formulary. And we have a growing presence in the community. We're becoming both a payer as well as a provider, and a lot of care coordination by our own physicians, nurses, and other clinicians is part of that piece. Let's go to the next slide. It's just sort of my last background slide to help you understand what our global payment looks like. We allocate our annual budget to our facilities based on a risk-adjusted capitation model, 90% of which is driven by clinical diagnoses and care practices. And we have additional adjustments for geographic differences in pay, for the amount of research and education that goes on. Think of this as kind of like the adjustments that Medicare has for teaching and research. And of course, we do have kind of a system to account for high outlier, high cost patients. That accounts for less than 1% of our budget allocation. We tweak this model every year because fairness requires us to make these adjustments. And we're looking against both system performance on efficiency and also our quality performance. So let's go to the next slide to talk about our availability of data. For a lot of practices in the community, you're relying on data that may be aged 6, 12 months, sometimes even as long as 18 to 36 months. Our performance feedback to our provider teams is near real time. I say it's near real time because I pulled this report on August 22nd, and you can see in the fine print that it was refreshed on August 21st. So we do allow some processing times. It's updated roughly on a weekly basis, and for primary care, this is adequate. But our performance reports not just provide practitioners and teams with how they're doing currently, but also anticipating what are the opportunities for the veterans that are scheduled to come to clinic in the coming week, and what gaps may exist. You can click on these links and you can pull up actual veteran identifiers and see what interventions like a flu shot or a pneumovax might be missing. And so we find that that's extremely important because simply providing performance feedback without the context to make it better on the individual patient level is basically a form of torture, and it's contributing to burnout across physicians in this nation. Let's go now to talk about efficiency. I have a slide that I'm not going to discuss how we monitor efficiency. We use a multivariable regression analysis called stochastic frontier analysis. I think many of you on this call are familiar with that. For those that aren't, that additional slide and the references in this deck will help you. But even with our system, with strong incentives to efficiency and a variety of other mechanisms to look at performance, we have variation. Now, some of this is kind of interesting when you get down into the local contextual level. So you see, for instance, higher inefficiency or lower inefficiency in the Northeast and the upper Midwest. That tends to be a little bit different than the Medicare picture on utilization. And that is largely reflecting population shifts where veterans both from attrition as well as active out-migration, are moving to the Sun Belt. North Carolina, for instance, recently passed legislation that exempts veterans from income tax. And we are seeing a huge movement of veterans to that state. And that has implication for workload, but our payment systems have to catch up because our risk-adjusted capitation is based on performance a couple of years prior to the present. And so you can see now, if you are relatively under-resourced, you are forced to become more efficient. If you are over-resourced, those shifts don't take place immediately. And so that's a big factor. The other factor we see are practice patterns that are developed through private sector contact. Our clinicians do not work in a vacuum. They come out of medical schools that often have local practice cultures. They often spend time on both sides of the street, so they may have a faculty appointment or a private practice, and they spend a certain number of half days in a VA clinic. And so capturing all of that and anticipating it is extremely difficult, and it requires a very granular analysis of performance, which this level of analysis doesn't give us. So let me move on to something else that we do with this stochastic frontier analytic approach. We are able to see some things. First of all, these boxes represent individual VA facilities where we've plotted efficiency against quality as well as patient experience. And what you'll see, by the way, is in general, the more efficient sites are actually doing better on quality and experience. So we don't think there's a trade-off, a negative trade-off between being efficient and providing high-quality care. Our best practices are doing well both on the quality end and on the efficiency end. And let's go to another side. This is just a conceptual diagram. We can take out our high-level analysis and parse it down to the components that are driving cost efficiency. And I just want to highlight a few things for you. In the 11 and the 12 o'clock position on this chart, what we see are potentially unnecessary days in the hospital and ambulatory care sensitive admissions still being areas of opportunity. So even in a system grounded in primary care, we have room to improve on the effectiveness of primary care. Many of the excess days of care, by the way, are also driven by things like the challenge in post-acute care. That's something that we don't have sufficient capacity for, and it's a problem for the private sector as well. The other big opportunity, which is roughly at the 6:30 position on this clock, is community care. As we grow our referrals to the community and we have practitioners that are not aligned with our practice culture and we lose direct contact with the veteran, fragmentation becomes a big problem. So quite honestly, we are looking to the proposals that CMS is discussing, that Mark just discussed, to help us in our new hat role as a payer of care. And this is now driving billions of dollars of our total healthcare budget. Finally, I'll leave you with the next slide, which is the challenge of low-value care. So we just walked you through some high-level regional differences in efficiency, but getting down to a more granular level, we partner with our health services researchers. Tom Radomski is at the University of Pennsylvania and the Philadelphia VA, and a colleague of Amol's, to look at testing. And you would think that in our environment there is not an incentive to over-test. And in fact, we probably have less low-value testing, like PSA screening in older adults or non-specific back pain imaging than Medicare. But it's only a little bit less, and we still see differences. Some of this is accounted for by veterans that are referred to community provider, but we still have work to do internally with individual physician practice teams. And work is ongoing right now to develop specific performance metrics to give people real-time feedback on these types of low-value care. And I think that this is probably one of the biggest frontiers for quality measurement in the coming years. And I think that's probably our last slide. I just had, again, the references and some background for your reading pleasure later. Back to you, Paul.
Great. Thank you, Joe. Next, we have Kate Freeman, who is the Manager of Market Transformation at American Academy of Family Physicians. Please go ahead, Kate.
Thank you, and thank you all for inviting me to be here with such a powerhouse panel. I'm very genuinely flattered to be here and speak to kind of the thinking of the Academy. Next slide, please. So to set the stage, I wanted to just kind of outline who we are as an organization. We're the National Association of Family Physicians, which represents close to 130,000 family physicians, students, and residents. And we're the largest single specialty medical society in the United States. And we're the only one devoted solely to primary care. Our membership obviously spans a diverse, ages, ethnicities, races, practice types, geographies, and specifically within that, we also monitor kind of the distribution of the employment status of our members. So over 70% of our members are currently employed by a health system or a smaller independently owned practice. This actually becomes even higher among new physicians. New physicians are employed at a rate of about 93%. So with all of that being said, could you go to the next slide? I think this is a pretty well-known report to this audience, but I think it's worth repeating that we believe primary care is a common good, and the public interest is best served when we strengthen the primary care system as the foundation to a high-performing health system. So the payment approach to primary care should reflect this important status and the unique position that primary care holds. Payment approaches that work well for others who provide kind of very specific episode or time-limited care to individuals are not the same and not as appropriate for the kind of continuous, comprehensive, and coordinated care that primary care provides. So, the NASM report really was an opportunity, and it really enhances the Academy's position that we need to move away from an undervalued and overburdened fee-for-service system for primary care towards a sufficiently funded prospective primary care payment system. Next slide. So with this in mind, the Academy developed a set of principles for primary care payment. And really what is foundational to this is that the core tenets of a well-functioning health system rooted in primary care includes increased investment through predictable prospective revenue that are risk adjusted to reflect both the medical and social risk factors and supported by multiple payers and informed by robust information that really supports optimal patient care and provides timely feedback to both physicians and their care teams. We do believe that it's really should be everyone's goal to move out of this pilot, test, demonstration model mode of thinking to supporting this kind of primary care payment in a more sustainable manner. And when we think about the land definitions of value-based care and value-based payment, paying for primary care differently, in our experience, not all value-based payment arrangements adhere to the principles of primary care payment that we've set forth. So I think it's really important that we're clear about what we think will support and strengthen primary care's role in healthcare improvement. So today I'm going to focus my comments on a couple of things: risk, accountability, and health equity. Next slide. So we're going to start with risk. Next slide for me. You might have to click a couple times. I think there's animation on this slide. So we know on average that AAFP members contract with 7 to 10 payers, and at least a quarter of our members are working with 14 or more payers. And each of these payers have disparate payment programs, reporting requirements, prior authorization requirements. So when we're thinking about accountability, given the segmentation of the payer market, there are actually very few primary care practices that have the critical mass of patients, let alone individual physicians, to assume significant risk on their own. When you think back to the slide that talked about 70% of our members being in an employed setting, those other members that are really in an independent practice, they just don't have the margins to take on significant downside risk. That's not saying they don't have the margins to take on any risk, but really significant downside risk, I think, is a challenge for them. The other thing is that the assumption of risk is about much more than just the size of a practice. In order for primary care organizations and practices to assume risk, they actually really need to be well informed about the populations for which they are at risk in ways that also don't place all of the burden on them, particularly when there are multiple payers involved. So this is really where we see payers playing a really important role through participation in things like efficient multi-payer models that aggregate data and provide centralized support, including information sharing and performance feedback. And this might sound aspirational, but I think there are actually some really great examples of this in the real world, especially in several of the CPC Plus regions that should be considered actual successes of the model, even though the overall model evaluation did not appreciate the regional variations of those successes. Next slide. This is another consideration when we're thinking about risk and scale. So most of our members, again, are employed. And this is an article that looked at kind of the value-based performance and quality incentives in physician and specialist, primary care and specialist contracts. And what they found is most primary care and specialist compensation arrangements do include performance-based incentives, but they averaged less than 10% of compensation. So I think a flag for when we're thinking about moving to these types of arrangements is when we we shouldn't be putting downside risk on employed primary care physicians who don't benefit from upside gains in their employment contracts. So thinking about re-envisioning those employment contracts to reflect the incentives and the payment methodologies, which currently is not happening as appropriate. Next slide. The last thing about risk is really thinking about it through a health equity lens. So the current methodologies for risk that have been tested to date really inadvertently penalize practices serving low-income and other vulnerable patient populations with more clinical and health-related social needs, as they may currently have higher total cost of care than is expected based on, say, their HCC score. Lower Medicaid payment rates also leave little room for savings to be actualized. So there are a few ways to think about how we can better structure payment models to alleviate this. One is really incorporating equity at the onset of payment design and considering it as a fundamental component of the value proposition, especially for these kind of practices serving these vulnerable populations, maybe rural or smaller practices. We also should consider more of an emphasis on improving patient outcomes and less on reducing total cost of care. And then I think kind of the obvious statement of including robust risk adjustment that includes demographic, clinical, and social determinants of health is also critical. Next slide. So next I wanted to focus on integration, coordination, and accountability. And this kind of gets to the conversation that we've been having today. There's a distinction, I think, between specialties who should be integrated within primary care, such as behavioral health, pharmacy, social work, nutrition, as opposed that are being coordinated with primary care. And that's not to say that those types of models like cardiology and oncology couldn't or shouldn't be nested into these total cost of care models. But I think the incentives need to be appropriately structured to reflect the types of relationships and responsibilities and accountabilities that are within those relationships. Next slide. So for those of you who are not aware, AAFP is headquartered in a suburb of Kansas City. So we do know good quarterbacks, and I believe the AAFP also knows good family physician quarterbacks. So I thought we'd talk a little bit about the quarterback analogy. So if you think about what it takes to be a successful quarterback, it really takes having, a set of well-planned plays, your playbook, and with delineated responsibilities for each member of the team. And they also receive kind of real-time, ongoing feedback about their performance to course correct from their coach, right? And usually just one or two coaches. To be successful, primary care physicians and their care teams need the same thing. This is challenging when they serve as a quarterback for patients who come with their own individual playbook, team, or network, and different feedback mechanisms determined by their payer. So if you imagine back to the kind of, most of our members have 10 to 14 payers that they contract with. It's really hard to be successful when you're receiving feedback from 14 different coaches with 14 different playbooks at the same time. So I think really what this highlights for us is that a multi-payer strategy that includes a common approach to payment and evaluation, including expectations around what's integrated within the care team versus what's coordinated, is absolutely essential to equipping primary care physicians and their teams to be successful as their patient's quarterback. Next slide. And the last thing I wanted to focus on is this idea around incentivizing screening and referral for health-related social needs. Next slide. So I think it's pretty clear that we have a fractured reality when it comes to thinking about screening and referrals, how they're paid for, how they're incentivized. The AAFP is very supportive of the goal of reducing health equities and believes that social drivers of health should be identified as risk factors and used for risk adjustment, as I stated. We also agree that it's really important that healthcare teams screen for health-related social needs and are able to connect their patients to social and community-based organizations that can help address those needs. But I think some of the challenges there are that these types of things are typically not billable under fee-for-service. And with the fee-for-service model really paying for discrete services, physicians and other clinicians have a challenge of appropriately being incentivized. So I think there are a couple of things. The overarching goal should be to drive improved health for historically marginalized and medically underserved populations. And addressing health equity and social drivers of health are community issues that really require community solutions. A lot of this is very local and regional. So many communities don't have adequate social resources or community-based organizations to help meet their patients' needs, nor are they resourced with the funding, skills, or staff to accept referrals from the healthcare system. Next slide. So if the dual intentions of the healthcare system are to move to value-based payment and to advance health equity and reduce disparities, I think we need to reconcile this fractured payment and support system. So there's a couple of things that we think are really essential to do this. The first is that, especially for primary care, prospective payment and increased investment really will support screening and referral that's typically not covered by fee-for-service, in line with the payment principles that I spoke about at the beginning. The second is thinking about the community infrastructure. There are a lot of communities that have bidirectional referral, closed-loop referral systems with community-based community care hubs. And I think the incentivizing the development and use of these community care hubs or other kind of payer and provider agnostic centralized referral systems would ease the burden on all parties involved, including those community-based organizations that are best equipped to address patients' social needs. So I think, and then I would just really like to plug that screening is a care activity that merits payment, both in fee-for-service and in alternative payment models. But I do think that a prospective payment approach really helps allows flexibility to care for patients in the ways that they need to be cared for. Next slide. So just to wrap up, we believe primary care is a common good that is best resourced by increased investment through predictable prospective payments, but changing the payment structure is really not enough. We need to re-envision physician employment contracts to really reflect the payment environment in which they're participating. And payers really need to understand that primary care physicians' first priority as a patient's quarterback is to their patients, and coordinating the playbook at a regional level can really have high returns. In terms of risk, accepting accountability is really about how practices are equipped for success as much as the size of the practice or the number of patients. And I think, foundational to all of this is that health and social care systems need to be adequately funded and connected to achieve the visions of health equity. So with that, I'll turn it back over to you, Paul. Thank you all.
Thank you, Kate. Next, we have Dr. Nancy Keating, who is a professor of healthcare policy at Harvard Medical School and professor of medicine and practicing general internist at the Brigham and Women's Hospital. Kate, please go ahead.
Great. It's a pleasure to be here today speaking with you. And while I'm a general internist, I study oncology care, and we're going to focus today on what we can learn from oncology care. Next slide, please. I'll start by saying that I'm clinical lead of the CMS Oncology Care Model Evaluation Team. I'm going to mention OCM today, but any mention reflects work that's been published on our annual reports. My comments and opinions are my own and not reflective of those of CMS. Next slide, please. So what do we know about accountable care payments and alternative models for oncology care? To date, there have been several studies that have demonstrated little to no effect of ACOs on overall spending, care at the end of life, surgical care quality for patients with cancer. Next. This is one example. This study used a difference in differences analysis to compare care and practices before and after they joined ACOs, and looked at, compared with other practices that were not in ACOs, and found no difference on care for cancer patients with a definitive impact estimate of $11. Next slide. This graphic depicts the complexity of cancer care across the disease spectrum, from screening and diagnosis to primary treatment, surveillance, recurrence, and end-of-life care. At each phase, there's various different types of physicians who provide care to patients, including primary care physicians, medical oncologists, surgeons, radiation oncologists, palliative care doctors, and others. And next, click. And here, if you think about people that are diagnosed with cancer, primary treatment also involves multimodality therapy from surgeons, medical oncologists, and radiation oncologists. Next slide. Yet this receipt of multimodality care is rarely provided by doctors who are billing in the same practice or tax ID number. These are data from a study of patients, Medicare beneficiaries newly diagnosed with lung, colorectal, or breast cancer. And among patients who received more than one treatment modality, surgery, chemotherapy, and or radiation therapy for their cancer, the proportion who received all of the modalities from the same practice tax ID ranged from 6% for colorectal cancer to 17% for lung cancer. Next slide. The next question we would ask is, what is the choice set for an ACO that wants to identify high-value practices with whom to refer patients? This map shows hospital referral regions across the U.S., or HRRs, by quartile of the number of medical oncology practices treating fee-for-service Medicare beneficiaries. And HRRs in red have only 3 or fewer oncology practices in their choice set across the entire HRR, suggesting that they may not have a whole lot of options when they're thinking about where to refer their patients. Next slide. I next want to share some findings from our team's evaluation of the Oncology Care Model, or OCM. OCM is an episode model for patients with cancer undergoing chemotherapy, defined by CMS as traditional chemotherapy as well as targeted therapy, immunotherapy, or hormonal therapy. And there were 201 practices participating at the start of the model. It was a voluntary model. And through 2019, these practices had treated over 700,000 chemotherapy episodes. Next slide. In OCM, the practices provide care for fee-for-service Medicare beneficiaries or a small number of patients from some other models. This was actually envisioned as a multi-payer model, although very few other payers participated. So the patients in blue in the middle are the patients that are fee-for-service Medicare beneficiaries who are initiating chemotherapy. All the practices' other patients are in the gray box below that. These are patients from other payers or patients at other phases of illness who are still seeing a medical oncologist. And for payment, the Medicare pays fee-for-service for all the care, but in the blue right box, you see they also pay a $160 per patient per month payment during the 6-month episode. These payments provide funds to support practice transformation, which was a key component of the model. OCM also incorporates performance-based payments, here in the purple. If quality and spending goals are met, practices had the opportunity to share in savings. Practices participating in 2-sided risk contracts could also face penalties, although this was not a popular choice in the early parts of the model. Next slide. This slide shows total episode payments for the 6-month chemotherapy episodes for OCM on the left and comparison episodes on the right. And then there's the baseline period, 2014 to 2015, and the intervention period, 2016 to 2019. As you see here, total episode payments increased in both groups over time, from about $28,000 in the pre-period to about $33,000 in the intervention period. The colors reflect the different types of Medicare payments. So orange is Part A payments, which didn't change at all over time. The blue are Part B payments, and the green are Part D payments. Both of these increased over time. And notably, the dark shading bars in the blue and green reflect the chemotherapy-infused drugs in blue and the oral chemotherapy drugs in green. And these increased substantially over time. These drug payments by 2019 were reflecting over 57% of the total episode payments for these episodes. Next slide, please. This slide shows our difference in difference analysis. To orient you, the baseline and intervention periods for OCM and comparison episodes are toward the left side, and in the red box is the difference in difference estimate. As you see here, we found a relative payment reduction of $279 for all episodes combined. And on the bottom, you see where we stratified based on the higher risk episodes and the lower risk episodes, the latter being primarily breast and prostate cancer patients receiving hormone therapy only, which were included in the model. And what we found here was that, in fact, for the higher risk episodes, total episode payments decreased by $503. The lower risk episodes, we found a relative statistically significant increase of $151. I'll point out that these estimates do not include the monthly enhanced oncology service payments, these $160 per patient per month, which on average were about a little over $700 for the episodes. Next slide, please. So this slide shows changes by cancer type in total episode payments. And you see here that the savings that we observed were primarily among 4 high-volume cancer types: high-risk breast cancer, lung cancer, lymphoma, and colorectal cancer. Next slide. So what about quality? OCM had 6 quality measures, 2 assessed using claims, emergency department visits, and hospice use, 3 assessed using patient practice reporting, pain intensity being quantified, or having a plan of care in place, or screening for depression and follow-up. And then finally, there were patient experiences of care that were reported by patients and collected in surveys that we conducted quarterly through all of the practices. Next slide. 3 of these measures could be assessed in both OCM and comparison episodes, and those measures are shown here. Our diff and dip estimates showed no change, basically 0, in quality for OCM relative to comparison episodes for these measures. And these, again, are measures for which practices were being held accountable. There were also no changes in quality for a variety of other measures that we studied in our evaluation. Next slide. CMS has just announced the follow-up to OCM called the Enhancing Oncology Model. This is another voluntary model. It will focus on patients with 7 higher risk cancer types, including breast cancer, chronic leukemia, colorectal, lung, multiple myeloma, prostate cancer, and lymphoma. Notably, they will not focus on the lower risk cancers that were part of the oncology care model. And the model addresses quality by requiring engagement in care transformation through redesign activities and engagement in quality measurement and reporting, all similar to OCM, as well as in this new model, activities to advance health equity. Next slide. CMS has also been developing other models relevant to oncology care. The radiation oncology model was proposed as a mandatory model that would provide prospective payment for 90-day episodes of care for 15 cancer types undergoing radiation therapy. There are rewards for maintaining and improving quality and patient experiences. However, Congress delayed the model to start no sooner than January of 2023. Then CMS then delayed it further to a date to be determined through rulemaking following public comments that were due in June of 2022. Next slide. So there are a number of challenges to alternative payment models in oncology, some of which have been pointed out already. So first, cancer care is quite heterogeneous. It depends on the cancer type, the stage, the tumor characteristics, as well as the phase of illness. And current risk adjustment is limited in its ability to account for differences in case mix. Second, patients receive cancer treatment from surgeons, radiation oncologists, medical oncologists, and others. And as we discussed earlier, they're often in different practices, or at least billing under different tax ID numbers. And finally, quality measurement in oncology care is early in its development. Next slide. So how might oncology care be integrated into ACOs or other total cost of care models? Well, we need to help ACOs identify high-quality, low-spending practices with whom to contract. But as we talked about earlier, the choice of practices may differ depending on cancer type and stage and treatment, and some areas have very few choices of oncology practices altogether. Finally, there's substantial challenges to measuring quality given the heterogeneity of disease, as well as small numbers of patients with certain cancer types in a given practice, which affects the reliability of quality measures that you might want to assess. Next slide. But there's also challenges, obviously, to episode method models, as we've seen with what we've learned from OCM so far. Episode models need to focus on a specific phase of disease and a type of care, like chemotherapy or radiation. And even then, there's substantial heterogeneity, as we saw for OCM when there were savings for only a handful of cancer types. This increasingly narrow focus then omits many patients who are receiving care, and it also omits a lot of different types of care delivered, like survivorship care and end-of-life care. That type of care might be best shared with primary care providers. Finally, there are complexities of model overlap. Next slide. I'll just highlight a few pressing needs. I think we urgently need better data on quality and spending at the practice level. Unlike the VA, most practices have very little data from outside of their own practice and often very little data even from inside of their own practice. We also need more testing of various strategies for episode and carve-out models. And here, mandatory models can be particularly informative because they avoid the selection issues of voluntary models, even if they're unpopular among physicians. And finally, we need testing of models for shared care. And I'll leave with this one more set of data from a large national survey of oncologists who reported about who manages the surveillance care for patients following primary cancer treatment. This shows the proportion of oncologists reporting that they took responsibility themselves in blue, that they share responsibility with the PCP in purple, or that the PCP or another physician leads the care. And you see that there's a lot of purple, and you also see that these things vary a lot depending on what the issue or the problem might be of survivorship care. And Obviously, this creates a lot of challenge when the oncologist and the PCP or other docs are not in the same practice. Next slide. And with this, I just want to acknowledge some of the collaborators who contributed to some of the work that I presented today, as well as some of the funders. And I'll look forward to the discussion. Thanks very much.
Thank you, Nancy. Lastly, we have Rob Mechanic, who is the Executive Director at the Institute for Accountable Care and Senior Fellow at Brandeis University, Heller School of Social Policy and Management. Rob, please go ahead.
Okay, thank you, Paul, and thank you to the PTAC team to inviting me here today to talk about ACOs and specialist care. We go to the next slide, please. I'm going to start off with a summary and then get into some more details later. But my main observations on this topic, number one, specialist alignment is a high priority today for ACOs. Obviously, Mark showed the data on the proportion of care that is attributed to specialist care. It's the majority. And so this is important to them, but as I talk to ACOs, the current level of alignment or engagement is generally low. There are a lot of challenges, many factors that make this work challenging, including the complexity of organizations, the complexity of ACOs, which I'll talk more about, the fact that there's poor interoperability, which limits communication and collaboration, the prevailing fee-for-service incentives, even within ACOs and within large systems, and the whole specialty culture and the volume culture are all factors that create some challenges. A number of folks have talked about the lack of data and metrics. This is particularly important, I think, in quality, where we feel like there's just a desert in terms of good quality measures for specialists. ACOs have claims data for all of their patients, but it's really only partial data when they look at any individual clinician. They have some of their data. We believe to really evaluate specialist care, you need some type of an episode grouper. There is, as I said, very limited quality data. And then I believe sort of on the margins that specialist financial incentives are probably not going to be key drivers of change. There are other things that may be more important, referral volume being one of them. I think one of the things that Nancy ended with about helping ACOs identify high-quality, low-spending practices. If I were going to propose a direction for policy, that's the direction that I would go in. Go to the next slide, please. Just a brief description of the Institute for Accountable Care, since many of you may not have heard of us before. We were formed a few years ago. We're an independent nonprofit formed to conduct research into policy and best practices around accountable care. We've got a small team of analysts who works on the Medicare database, where we have access to all the fee-for-service claims, A, B, and D, and a number of other data files. We do a lot of work around modeling and analytics of the MSSP program and performance and benchmarks. We work with a number of episode groupers, particularly the episode grouper for Medicare, which was developed under a contract with CMMI, as well as the BPCI advanced model. We do program evaluations for individual organizations to look at their programs such as care management or home-based care. We've run a number of learning collaboratives on various topics in collaboration with the National Association for ACOs, and we're currently working with 6 large ACOs on just this issue on using episodes of care to try to improve specialist engagement. Go to the next slide, please. So ACOs are complicated, and people say when you've seen one, you've seen one. In the Medicare Shared Savings Program, ACOs range from a size of about 30 providers to over 11,000 providers. And they're made up of a number of distinct physician groups. Many of these physician groups never worked together prior to the ACO being formed. And so on average, the average ACO today has about 34 physician groups as part of its ACO. If you look across the continuum, each bar represents about 50 ACOs, and the number there is the mean number of physician groups. So really, you have very few ACOs that are just a couple of physician groups. More likely they have multiples, and they are independents of various sizes and various capabilities. I would go to the next slide, please. One of the results of having multiple independent groups brought together in these arrangements is that they are not on the same technology platform. So this was a study that was published earlier this year. It's based on a survey of roughly 160 ACOs. You'll see here that of the 160, only 9% of them have all of their providers on a single EMR, and 77% of them have 6 or more electronic medical records among the provider groups. And so that makes it very difficult to aggregate, to communicate, and I think it limits, of course, the ability to coordinate care between primary care and specialists that are in different groups. Go to the next slide, please. Another important point is that a lot of the specialist care provided to ACO patients is provided by non-ACO specialists. And just to give you an illustration, what we did is we took the 2020 ACOs, we broke them into 4 groups, which I'll call PCP-focused, PCP-oriented, specialist-oriented, specialist-focused. You can see the number of groups. And the third column here is the percentage of primary care physicians as a share of total physicians in the ACO. If we could go to the next slide. So what we did is we took each of these 4 groups, we looked at the patients inside each ACO, and we said what proportion of the care was delivered by ACO physicians. And so you can see on the left-hand side, majority of the primary care for all categories of these groups was provided within the ACO. That's a little bit tautological because patients are assigned to ACOs based on their use of evaluation management services. But when we get over into medical specialist and surgical specialist care, you see on the left-hand side, the PCP-focused or the red bars, some of those groups have no specialists or just a couple of specialists, so that they get virtually all of their care outside. And we go on to the more specialty-oriented ACOs, and they're still on average getting about 30% of their care, what I'll call in-network, and the rest of it out-of-network. Now, some of that out-of-network care may actually be specialists who are part of their organization, but that don't participate in the ACO. If you go to the next slide, this is just breaking it down by percentiles, and you can even see over on the far right-hand side, even the ACOs that do the most, the highest proportion of the specialty care within their ACO physician network are still 50, 60% of specialist care, so you've got half still going outside. You can go on to the next slide, please. All right, we did a survey of specialist engagement across ACOs. This is by no means is this statistically, but we'll say it's a convenient sample. It's not meant to be generalizable. We've got 64 responses. The respondents are really non-typical. They tend to be larger, they tend to have hospitals, and they tend to employ their specialists. But this does give you sort of a flavor for where ACOs feel they are in this area. If you could go to the next slide, please. So we asked them we listed a number of activities, and we said, is your ACO involved in this? Would you consider this to be a major activity, a minor activity, or you're not involved? So you can see across these 4 activities we have listed there, working with specialists to develop care pathways, about a third, that's a major activity. Giving specialists unblinded performance reports, 12%, say it's major, probably due to the lack of good quality data. Directing referrals to high-performing specialists. This is an area of very high interest in the ACO community. Less than 20% say it's a major activity. And then finally, entering bundled payment contracts. Of these 64, 17% said, yes, we're doing a lot of it. 58% were not involved with episode payments at all. Go to the next one, please. We also asked them about their use of financial incentives to reward specialists, and the largest response was we don't. 42%, followed by a third giving some incentive based on cost or utilization, 31% other, which is typically citizenship, participation in committees, other things like that, 19% clinical outcomes, patient satisfaction, and then a couple of them have an incentive for risk coding. Go to the next one. So one of the big questions here was, what are the challenges? What are the barriers to engaging specialists in the work of value-based care and controlling spending? So far and away, the number one, lack of data or metrics, especially quality metrics. Number two, the dominance of fee-for-service incentives, which are driving specialist behavior and specialist compensation. I think, as Kate noted, importantly, regardless of how the organization is paid, most of the providers' comp models are primarily based on RVUs. And so the more you do, the more you earn in most cases. There's a bandwidth issue because many ACOs, they have a fairly lean staff, and specialist practices also, they're working on providing care, and they may not have time to sit down and say, how do we engage better? How do we do our work better with ACO personnel? Many of them commented that the specialists were not interested in engaging with them in their work. And finally, there's a lot of uncertainty about how would you structure financial incentives given, or how would you select high-performing practices given we don't have good data. And for those that got into the issue of gain sharing, there is some concern about diluting shared savings dollars by taking money that was intended for PCPs and taking some of that and paying that to specialists. So these were some of the concerns that were reported in the survey. And if we could go to the last slide. Actually, it's not the last slide, second to last slide. And this chart, I think, really gets to the root of the problem, because when we look at ACOs, we say, well, are ACOs the dog or is ACOs the tail? Now, okay, here's the little ACO came up. There are some organizations that participate both in, Medicare Advantage, commercial, private ACOs, a group like HRACE Health. They're mostly capitated or full risk. The organization is an ACO. That's how they think of themselves. But in many cases, ACOs are part of a health system. They're a group. They may have some influence, but, in the end, the power is with the hospitals, the power is with the specialists, because those are the revenue drivers. And so the ACOs have some influence, but they're not really driving the train. Let's go to the last slide. So what are ACOs doing and what are ACOs thinking about? And these are sort of four things that have been referenced to us commonly. One is getting out there and trying to meet with the specialists, talking about their goals, trying to find ways that they can collaborate, trying to, tell them what the ACO is trying to do. Second piece is using episodes to measure specialist resource. Most individual organizations don't, they don't have, a handful do, but mostly they don't purchase episode groupers or run their own data. They'll go work with different contractors to look at specialty care. A third thing that some ACOs are doing is they're going to their own primary care physicians and they're surveying them on their specialist performance. And in this case, by performance, really they're talking about service level. Does the specialist communicate well with you? Does the specialist return your calls quickly? Does the specialist send the patient back to you with good documentation? Are they providing good satisfaction for your patient? Some of the health system-based ACOs are trying to set up within their systems more opportunity for PCP specialist collaboration. And that includes what I'll call hoops. I think one of your prior presenters in an earlier session talked about referral hoops. But for example, one group that we talked with recently said, a primary care physician can't just initiate a specialist referral. They have to document that they've had a conversation with the specialist and that the referral is appropriate before they actually make the referral. And what this particular ACO was looking for is they want their specialists to work with the ACOs to give them kind of more expertise and to better determine when you can manage the patient without the referral versus when you have to make the referral. Finally, directing referrals to preferred specialists, obviously for people who get most of their specialist care outside of their own physician network. This one is important, and more people are talking about specialist tiering models. But again, to do that, they need better data. They don't have all of the data, and so as a matter of policy, I think beginning to provide some of that data, as Nancy and Kate and others talked about, is going to be really important. So thank you, and I will conclude with that.
Thank you, Rob. Thanks again to all the terrific presentations. We're now going to open it up to the PTAC members for questions for our panel. Chinny?
Wanted to address this to Robert, but everyone as well. So one of the things that when we look at ACOs that often is criticized is that the burden tends to be placed on the primary care physician from an administrative perspective. And I think as well intended as a lot of programs are, it continues to place a huge burden on the PCP to just fill out paperwork, make phone calls, do that kind of stuff. So how would you address that as you start to hold more specialty-centric, accountable organizations?
Well, so I think some of the burden comes from the requirements that are put on by the payers or the requirements by the government to report information. I think, a lot of the ACOs, and, I've spent a lot of time in my academic career interviewing ACOs. One of the things they try to do with primary care is to give primary care more tools and more resources so that they can spend more of the time caring and less of the time administering. I think, when we talk about trying to get primary care providers to have more conversations with specialists and coordinate, it's not so much making phone calls, but it's really having the conversations about the clinical work. And so I think, those are conversations that I would say are really important for the patients and the patient care. To the extent that the ACOs have resources and can put it into it, I think it is trying to strengthen the practices, again, so the PCPs can focus on the care and less on the administrative burdens of the models.
Let me add for VA, our primary care providers grumble about this as well, even though I think we have more mechanisms to support collaboration. It takes, I think, active intervention at many sites and for many specialties. There are formal contracts, which we call service level agreements, that specify what individuals will do. A lot of this is really putting the expectations up front. On the education and what we've done, again, and you can do this in a national system with infrastructure that's supporting, is provide teleconsultation services. And again, these tend to be very targeted, things like critical care with tele-ICU, but also telepulmonary care for some of the outpatient lung disorders that are quite prevalent. And that actually tends to support the kind of curbside consultation that happens naturally in a big medical center, but then when you have, say, a rural community-based clinic, those hallway interactions can't occur, and so you have to develop means to do that. But you got to also include some way to give workload credit to the specialist and the primary care clinician who's engaging in these interactions, and that always is a challenge, and we have lots of discussions what we want to give credit for, because we capture an RVU equivalent, and that's how we rate efficiency, but also what we don't want to capture, because we don't want to create a culture in which you basically check a lot of boxes and ring up the tab without being focused on the veteran's needs. So it's a struggle.
Yeah, can I just add to Joseph's comments about like workload recognition? Another way to put that is accountable care, and Rob presented, that additional work.
Mark, your connection, sorry, Mark, I'm going to interrupt. Your connection is not very good. You may want to just turn your video off, and then we may, because we didn't hear your response. You were freezing.
Okay, sorry about that. We've done a lot in ACOs to try to find a pathway for primary care physicians to have more resources to do important things that aren't supported under fee-for-service, like educating specialists, constructing data on episodes, trying to do selective referrals, expanding out their capabilities to manage more of especially aspects of care. But we're only using a tiny part, as Rob showed, of the overall resources that are going into care involving specialists. And just like it's really hard to ask primary care physicians to do all those things if they're just being paid on a fee-for-service basis, it can be hard to ask specialty providers to do more to be partners and engage in that effort if they're only being paid for doing elective procedures efficiently, or handling admissions efficiently, or other fee-for-service things. So I think that's why I think this idea of like having a nested model for specialists who want to engage and can engage, to put some resources into being on the other side of that care coordination, providing, and we've seen lots of examples of this around the country. So it's very hard for specialists to sustain under their current fee-for-service models of person-focused musculoskeletal care models that are coordinated with primary care physicians, cardiovascular care models that involve more longitudinal management of patients with advanced or complex conditions, end-of-life models involving specialists. When you make some of the same kinds of changes on the specialty payment side to facilitate that, like per person payments, and even if it's just stepwise, to help get that alignment to happen.
Great. Go ahead, Nancy. Yeah.
I might just add one more comment to underscore what Mark was saying, which is that as a primary care physician myself, our current model so over-incentivizes procedure-based care that it is impossible to get engagement when you have a patient that they did surgery on 2 months ago, yet the patient's having problems, and they wind up in my clinic because, our current fee-for-service model just has them wanting to fill their OR slots and not see patients in follow-up. So I do think this is so important to really figure out how to engage the specialist and have the specialists see themselves as someone who can help support the PCP. Like, I'm happy to see my patient if you will answer the questions that I can't answer. So, it's just a clinical example where it's really key.
Right. Thank you. Lee?
Yeah, I appreciate all the great presentations. I think that maybe we're starting to hear a consensus emerge between comments today from both Mark and Kate, as well as our presentations yesterday. But I'd invite more comment about this concept of in multiple overlapping population-based and specialty-based or episode-based value-based models, whether there really is a consensus that we think we're hearing that they should be nested in versus carved out. Then how, if they're really going to be nested in, how you actually see with some more details or commentary about how overlapping incentives could be structured. And then the third strain to this question, I realize is complex, is if we see a developing policy goal that it seems like the country needs to be shifting more resources into primary care from the fairly low 5% investment, how that can work in a nested total cost of care episode-based model.
So I'm happy to start with that. Ever since the beginning of these CMMI programs, there's sort of been struggles about how do we deal with the overlap between bundles and between ACOs. And I think it's fair to say that nobody's really come up with a satisfactory way to do it, because it's very hard to sort of independently say, well, what's the value that the specialist provided or the bundle participant, what's the value that the ACO provided, and do that really in a concrete way. I guess I would think about it as I like the idea of a nested model, but I think not all ACOs would be capable today of using a nested model. I think you would want sort of a larger organization that has its own specialists and can work with it internally. Again, I think what many of these organizations are missing are some of the tools and some of the data analytics. And if they had those and they're working with their own specialists, I think would make a lot of sense to bring this in as having some internal structure to how they work with their specialists. And I think that could be a really good tool for engagement. I do say, even though, I've made the comment about financial incentives on the margin, I do agree with Mark and Nancy that you do have to compensate the specialists for the time they spent in coordinating with PCPs. You can't just have it cut out of their income.
Just to add to that, I do think that the path forward is different for, as Rob characterized, the ACOs that are primarily physician-based, especially primary care-based, and those that are comprehensive or consolidated, including hospitals and a lot of the specialty care. There are some advantages, as Rob said, to having specialists and hospital care within your ACO. Unfortunately, right now, as we've just been hearing, most of the financial incentives in those organizations are still really tied to make your admissions efficient, maybe avoid some of the preventable medical admissions, but the financial margins are still there for a lot of specialty procedures, and not necessarily really that focus on what's the best longitudinal care pathway for a patient for preventing their pain or maintaining their functional status if they've got a musculoskeletal condition, or maintaining their function if they've got a cardiovascular condition, or getting the right initial treatment and the right long-term follow-up and end-of-life care for a cancer patient. That's where there are real gaps, and even a step, even if it's limited funding, shifting in that direction will be important. We think in our Duke-Margolis recommendations that this shift to a component of person-level specialty care payment for conditions should be mandatory, actually, to provide a shift in those dimensions. There's no reason in principle that organizations that do have specialty care and hospitals within the organization can't put that together. The money's all going to them. It just would be coming less in a sort of fee-for-service, acute episode only direction, and that can happen incrementally. You don't have to make dramatic changes over time, but I think it really would send a very clear signal that the specialty care coordination time with primary care is valued, and that specialty efforts, there are lots of creative efforts out there to do a better job of longitudinal care management, preventing admissions, intercepting diseases earlier, is highly valued. For the smaller physician-led groups, we think it should be at the discretion of the physician-led group. I personally am not sure that we want in the future all fully integrated organizations. There are a lot of very well-functioning primary care ACOs and a lot of independent specialty groups that are pretty good at doing what they're doing too, and those could work together and maybe create some more competition and innovation as well. There, the hard part is making it clear to the primary care ACOs that it's not just all on them. They don't have to do everything within their additional PMPM payments or their shared savings, that there is a pathway here, if they want it, to not only tell a specialty group, hey, we like the way you're delivering care, but here's some ways in which you could get paid differently that, if the math is done right, are going to make us all better off, that will add more resources into this care coordination. So just having a model, a template they could go to, so they don't have to start from scratch with every group, and CMS putting some push behind that, I think you'd find that some groups, maybe not all, would take it up, and maybe we'd learn more about how to do that well over time. But we've got to augment the resources available for specialty care coordination for those primary care-led ACOs and for the specialists that want to work with them.
I think, Mark makes a lot of really great comments. One thing I would like to underscore that I think is similar for both, kind of primary care-led organizations and those that are more specialty focused is this need for kind of two things. So the data and information is so critical. And I think that this is important for both specialists and primary care. For a model, I think, Mark described it really well, that like some of these smaller ACOs probably don't need to be fully integrated, but they do need the data. And that's the same, that is the same for those larger organizations, more integrated networks. The other thing that I just would like to bring up again is that this doesn't work unless there's alignment across payers. It takes a substantial level of alignment in quality and payment and all of these things to really make a difference, especially for those smaller organizations who really don't have a lot of wiggle room in their margins to kind of deliver care differently. That if we alter the payment structure, give them the data they need, that's when we really see a shift in how primary care practices integrating with specialty, coordinating, can really deliver high-value care to patients.
That's great. Thank you. Angelo, did you have a question? Oh, you got answered. Okay. Larry?
Excellent presentations. The gears in my head are spinning. I'd like to ask Mark a question. I'm intrigued about your model of baseline payments combined with bundled payments for procedural services to specialists. Something we've heard both days of this conference about getting specialists an on-ramp, trying to find an on-ramp to get at least some of the specialty services rolling. Have you experimented at all with looking at the specific characteristics of the disease for deployment of specialists? For instance, more high beta type diseases that would be higher cost per capita, that would be maybe have a higher percentage of disease-specific cost, that would make it more specialty focused. Have you done any work on that degree of granularity?
It's a really good question. I think once you get outside of the hospital-based episodes, those four walls that Amol was talking about earlier, there are not many specialties where the care is only, or maybe even mainly, and not many conditions where the care is only provided by specialists. You run right into exactly the issues we've been discussing. And maybe very different kind of longitudinal care models than what we're seeing today in this fragmented fee-for-service driven approach. A great example of that is musculoskeletal, both for osteoarthritis and for back pain, where I'd refer everybody to work by Kevin Bozick and colleagues, some of which we've collaborated on, which can show 30-40% reductions in procedure rates while giving functional status and capabilities, which is what matters. Some enhanced primary care roles, but also enhanced roles around physical therapy and the like. And here, Larry, I just would emphasize that there's a lot of heterogeneity out there. There's some specialty groups that can do this now and are really stuck because they don't have these more person level financial arrangements to support them getting paid for things other than doing procedures. There are other groups that don't, and there are many primary care groups that say, well, we can do a lot of that management, triage to behavioral or pain management where that's appropriate, physical therapy where that's appropriate. We expand our capabilities. We can do that. I think that's fine, but that's why I like this nested model idea of, for physician-led ACOs, give them the option of setting up a partnership. If they want, they can adjust the payment amounts with a specialty group group if they think the specialty group can really help them, or they can take on some of that themselves within their ACO if they really are that advanced. I think we don't know what the capabilities are. I think we do know that most organizations and most specialists are not able to deliver, this kind of truly person-focused longitudinal care model yet. And so we need at least some initial steps to get that going, and a recognition that some, just like we saw with primary care, some are going to be more advanced, be able to take to it right away. Others are going to need an on-ramp and more time.
Jennifer?
Thank you very much to each of the speakers. Your presentations were really fascinating. Over the last 2 days, there's been a common theme around priorities. The first is around data or lack thereof, it being accessible and actionable and meaningful. The next is around quality measures and really the big opportunity that exists around measurement from a process and an outcomes perspective. But yesterday we talked a lot about, or we heard from our experts that they agreed that there should be large disincentives for participating in fee-for-service, some recommending mandatory participation. I'm curious if you all agree with their recommendation that there should be large disincentives for fee-for-service, and if so, what that would look like. What do those incentives look like?
I guess I'll start. I'll give you my personal opinion. First of all, one of the things that the ACOs are advocating in Congress right now is for the extension of the advanced APM bonus under MACRA, which it goes away in 2024, but essentially this year is the last year to qualify for it, and it's a 5% bonus for the providers in the ACO. Some of your presenters from the prior day, I know in their writings, have talked about maybe something like an enhanced primary care payment for providers in value-based payment models, say 10%. You could really focus this, again, I think that the AAPM model has some flaws, and you could really sort of refocus the payments onto the patients who are attributed, who are in those total cost of care models. But, if we think about physician fees essentially being flat since 2015, I think some added incentives on top of that, certainly for primary care and maybe for targeted specialists, I would be in favor of that.
I will just add from the primary care perspective that I think that without an appropriate place to go, disincentivizing fee-for-service, especially for practices that are serving medically underserved or vulnerable populations, this is a health equity issue, right? So if we disincentivize fee-for-service and we make it for those practices that already have really slim margins to, serve their patients in these, communities where they really need a primary care physician, I think without an appropriate place for them to go, we risk exacerbating disparities. And I don't think that's what the intent of any of this is. So I think maybe flipping the question and saying, what's the appropriate incentive and how are we getting that to all of the, how is that kind of being dispersed broadly, and how do we kind of move away from fee-for-service and we build models that aren't built on fee-for-service? I think those are all maybe the questions where we could spend some more time and energy, because I do think as the more attractive you make alternative payment arrangements, the less attractive fee-for-service is.
Yeah, I agree with Kate entirely, and just wanted to underscore, I think CMS is doing some really innovative work here with some of their new models. And for example, with the Enhancing Oncology model, the monthly payment for your average Medicare beneficiary is going to be $70 per patient per month. So it's less than it was for OCM, but still up there. And if you are taking care of a dual eligible patient, you actually get $100 per member per month, and that additional $30 does not count towards your total episode payments. So I think I totally agree with this idea of the more we can make the alternative payment models more attractive, and particularly for practices that are taking care of historically marginalized and otherwise disadvantaged patients, I think that will make it attractive for some of those groups. And, it seems like fee-for-service is becoming less attractive because the rates have been so stable. But, I think particularly our procedure-oriented specialists are still making lots of profits. And so I do think we need to make the alternative payment models attractive to them as well.
I mean, there are good reasons to make the alternative payment models more attractive. I think as CMS has seen over the past decade, and I think Nancy's work showed too, it's hard to get significant budgetary savings in the short term in voluntary models. It does take investments, especially in safety net and historically under-resourced organizations to make these changes. The organizations that are, doing fine, thank you, right now under fee-for-service are not going to tend to sign up under voluntary arrangements. So perhaps a path that maybe starts with voluntary but gets over time towards mandatory would help. And this gets to the point about getting the critical mass. CMS has laid out a very clear goal for 2030, where I think we still have a lot of work to do. What are the interim steps between 2022 and 2030 that get us there? And I don't think, from a healthcare sustainability standpoint or a speed standpoint, we can get there just with voluntary models that have some sort of extra add-on payments to begin with, even though that's a really important step now. So some continued effort on how do we turn this shared 2030 vision into a clearer pathway to progress that's going to get to more alignment on reporting and all the burdens that multi-payer facing practices have to deal with today. Those are really important steps to bring down the costs and make it more attractive and give a higher level of comfort that we can make these changes mandatory. We don't have to just keep increasing the fee-for-service rates as a stopgap measure for our uncoordinated healthcare system.
So with that, I want to thank all of our speakers. This has been a very valuable discussion. Your input will be very helpful to the committee as we prepare our report to the Secretary. So at this time, we have a lunch break until 1:15 Eastern. We will have our public comment period, and then the committee's discussion of draft comments for the report to the Secretary. Thank you again to all of our speakers.
Produced by the U.S. Department of Health and Human Services.